Hi, my name is Anna. I'm a medical anthropology student, PhD student at McGill University in Montreal. In this presentation, I'm going to be talking about anthropology, hauntology, and some of the methodological possibilities that engaging hauntology offers to studying contemporary healthcare systems and health citizenships. I'll be particularly exploring a mode of ethnographic inquiry put forward by anthropologist Justin Armstrong, which he terms spectral ethnography. I'd like to explore how modes of engagement involved in this type of ethnographic inquiry could help anthropologists study changes occurring worldwide as public healthcare systems increasingly involve private companies to provide services. I'll be drawing on examples from the UK's National Health Services, in which I consider some of these changes to be exemplified. The concept of hauntology has gained quite a bit of traction in anthropological literature. Recent scholarship has demonstrated a concern to engage hauntological concepts in anthropological praxis. Jacques Derrida's concept of hauntology is an assembly of haunting and ontology. As such, it's a framework that enables engagement with absent presences, so spatio-temporal elements of the past, sometimes the present, and indeed future imaginaries that are embodied in these elements that act at a moment in the present. In 2022, an article in the Annual Review of Anthropology described the emergence of an anthropological hauntology as a distinctive field, acknowledging that the use of haunting as an analytic category is fairly new in anthropology. This new hauntology has been taken up by anthropologists in a number of subdisciplines, often as a way to study historical aftermaths of colonialism, slavery, and mass violence. In this presentation, I'd like to consider how and where anthropological hauntology can be harnessed to understand increasingly neoliberalized public health systems, and particularly to understand evolving forms of health citizenship in this context. That is, social citizenship as it intersects with experiences of health, illness, and care. I want to focus particularly on the United Kingdom's National Health Service, or NHS, to ground this discussion, as I consider it a post-socialist health system that involves increasing public-private hybridity. From its genesis in 1948, the NHS has been understood as an essentially socialist project. It is socialist in the sense of being built as a free and universal system that sought to decommodify healthcare and redistribute national income by delinking healthcare from individual contribution, as well as implementing collective ownership. However, several decades of neoliberal policies in the UK and the introduction of market mechanisms have led many to describe a creeping privatization of the NHS. Particularly the use of public-private partnerships, or PPPs, in publicly funded healthcare is accelerating across a broad range of services in many clinical fields, such as general practitioner services, diagnostic tests and surgeries, as well as in infrastructure and support services. Care pathways for patients can be fraught with myriad public-private providers. This may particularly affect long-term users of healthcare services, as PPPs have been implemented specifically for the support of people with chronic conditions. For example, with 80% of diabetic care provided in a community setting, approximately 1/3 of community care is provided by contracted private providers. PPPs have direct implications for how care is provided. The involvement of private for-profit organisations has been seen to entail significant changes to care provision, as these arrangements require new sets of institutional arrangements, accountabilities, care practices, and behaviours. I consider that the use of PPPs enables for-profit organisations to enact a certain spectral presence in the NHS. PPP contracts are not only notoriously non-transparent, but they allow private providers to operate relatively inconspicuously under the banner of the NHS. Furthermore, in the context of these profound changes to healthcare provision, the rhetoric about NHS provision has become increasingly disconnected from the empirical reality. In spite of evidence of increased private sector in the NHS, meeting the definition of privatisation, and private providers frequently linked to poor accountability, substandard care, and poor patient safety, the NHS as a publicly provided system continues to be lauded as a robust national cornerstone and key value. As such, there is a certain uncanniness to the reality of a company such as Virgin Care, a controversial private provider, running large swaths of community care in the UK. And there is good reason to think that PPP arrangements also have direct implications for patient citizenship and health citizenship in the UK. The NHS operates both as a material, place-based health service, but it is also embodied in public memory and imagination as an ideal of humanitarianism. British identity is described as strongly linked with the NHS, and the NHS is commonly described as a form of religion for British people. Thus, an important question is how these ideations of the NHS interact with lived realities of health services. I suggest that there are elements of evolving post-socialist healthcare systems, such as the NHS, that can be usefully described as spectral. As well as collective memories and ideations of the NHS, the policies, contracts, and public and private companies involved in PP arrangements enact a certain absent presence in material health services, and by extension, people's relationships with their health, illness, and with the state. But how do we engage with these haunted elements ethnographically to better understand the environments created in these hybrid systems and the lived experiences in these environments? Anthropologist Justin Armstrong's spectral ethnography offers guidance here to investigate experiences at the complex intersections of public-private hybridity. Armstrong describes spectral ethnography as moving beyond boundaries of the seen and spoken into interplays of space, place, objects, and temporality. He describes this approach largely regarding spaces of absence, where things have been removed, deleted, or abandoned. However, I think elements of Armstrong's approach may be engaged to illuminate spectral elements that haunt health citizenship in the UK, particularly if we follow an understanding of the NHS as a system in a state of post-socialist ruination. For example, Armstrong suggests spectral ethnography as a way of looking at culture as a network of interconnected resonances, echoes, presences, and other spectral accumulations that exist outside of the domain of the immediately apparent. It is a subtle rethinking of ethnographic space, a shift to thinking about ethnographic spaces as sites to study accumulations of cultural time, such as collective memory, regional imaginaries, state and popular histories. Approaching sites of healthcare in this way, in the altered care pathways created by myriad PPP services, may be a fruitful way to understand the intersectional relationships and interactions between the corporal realities of bodies, so physiological and psychological capabilities, material care environments, so the buildings and places in which care is provided, and spectral, more unseen elements like policies, memories, contracts, and ideations of the NHS that haunt the edges of people's experiences as they negotiate these changing landscapes of health and social care. To explore this, I'd like to give an example of my father's experiences of using a continuous glucose monitor to manage late onset type 1 diabetes. And I do this to explore passing out what Armstrong describes as ghost texts, so the invisible dialogues between people and their material and environmental surroundings in hybrid healthcare environments. A CGM is a small disc-like device that attaches to the arm of a person, and it is used to track, store, and analyze data through platforms and apps that communicate with the device. CGMs help people living with type 1 diabetes to more accurately, comfortably, and independently manage their diabetes by collecting data that indicate a user's blood glucose levels. My father, who lives with late onset type 1 diabetes, had a CGM implanted onto his arm in 2017. This was offered to him by his NHS healthcare provider, but it is made and supplied through a transnational public-private partnership between the UK government and a company called Abbott Laboratories, which is an American multinational company. In order to have the CGM readings shared with his NHS healthcare specialist, my father had to agree to Abbott Laboratories' terms and conditions directly, which include allowing this company to collect, store, and manage the data that is collected from his body by the CGM, thus allowing this American multinational company unlimited access to continuous monitoring of his blood was a mandatory condition for meaningful use of the CGM. This intimacy is manifested and mediated in uneven ways in my father's experiences. Abbott Laboratories might be understood to occupy what Armstrong terms a spectral significance in his life. Often they operate as an absent presence. Their unseen hand is ever present through the CGM and the app, but it is normalized by daily use. At appointments with his healthcare provider, the information collected by Abbott Laboratories is mediated through an encounter where the source that is monitoring his blood glucose levels fades into the background as the need for these readings to guide his ongoing care takes prevalence. However, at other moments, the spectre of Abbott Laboratories materializes directly and must be confronted. For example, when my father recently lost the passwords for the app that he needs to read his CGM, it was Abbott Laboratories' consumer call center that he had to call to reset his password, where he was reconfigured from a patient to a client. Additionally, the material information generated by the constant surveillance of my father's blood glucose by Abbott Laboratories is owned by them, and any ability to control how this data is collected, stored, and used has been highlighted as virtually non-existent. Through the CGM monitor, my father's body is unbound across spaces and borders into the hands of Abbott Laboratories, to whom he is tied by an uneasy form of necessity. I consider that the CGM can be usefully described as a folded object, in that it brings the traffic of different spectral elements into dynamic forms of proximity. There are many different elements involved here. Amongst corporal and spatial elements are my father's body and his blood, Abbott Laboratories, the smartphone he needs to accommodate the app, the diabetes clinic, and there are also important temporal elements inscribed into my father's relationship with the CGM. The years he spent working for the NHS, our family, his collective citizenship history in the UK, and his changing experiences of health and care. This vignette about my father's experiences is intended to help highlight how private companies are integrated into public healthcare systems in elusive and uneven ways. Excuse me. Spectral fragments of Abbott laboratories are embedded into healthcare services, objects, and the body of my father, sometimes quietly and other times with a jarring presence. Following Armstrong, it is important to remember that an object, a person, or a place is rarely one-dimensional, singular, or monovocal. Things and locations are endued with resonances that form their character and speak to their cultural significance. Spectral elements are folded in the CGM. They haunt this object and, by extension, the embodied praxis of my father's health citizenship. Public-private partnerships are accelerating worldwide in healthcare systems, incurring profound changes to how care is being provided. Recent scholarship has highlighted the imperative to understand evolving identity formations in increasingly layered and veiled iterations of capitalism. For example, Naomi Klein highlights how capitalist operations sit on top of more hidden parts that she terms the shadowlands. These are the mangled and dense understory of our supposedly frictionless global economy. PPP health services are exemplars of shadowlands, as contracts are notoriously non-transparent, involve transnational flows of capital, and allow private companies to operate relatively inconspicuously under the banner of the NHS. To understand the full implication of these transforming epistemologies of care in these contexts, so the changing ways that medical care is created, practiced, experienced, validated, and confronted, I consider that we need methods that integrate different ways of remembering, seeing, and experiencing healthcare systems in their different dimensions to understand the meaning of an irregular landscape of changes for patient citizens. Given the uneven relationships between empiricism, collective memory, objects, and space seen in modes of contemporary care, I consider that hauntological frameworks such as Armstrong's spectral ethnography offer fruitful methodological guidance. Thus, to meaningfully engage with contemporary forms of health citizenship in public-private hybrid environments, I follow Armstrong, consider the unseen is often as important as the seen. Engaging hauntological concepts in studies of neoliberal health policies will advance anthropological capacities to study these policies and, importantly, to resist them. Thank you very much.